How do we evaluate to figure out who is the right candidate for deep brain stimulation surgery or therapy? What is the DBS evaluation process? As I mentioned in an earlier video, the deep brain stimulation surgery, although very effective, is not for every Parkinson's patient. A completely guessed estimate or guesstimate is that maybe 2 out of 10 patients with Parkinson's disease are good candidates for this therapy, and this might be a very significant underestimation. It is not based on any appropriate studies, but more of a clinical impression. But how do you figure out who are those candidates? I talked in an earlier video on what benefits can be done with this therapy. So the goal of evaluation will be, one, to figure out who is likely or highly likely to get benefit from the deep brain stimulation surgery therapy, because it's a brain surgery. If you're going for it, you want to know for sure as much as you can that the therapy will be effective. And the second goal is to make sure that we rule out any undue risks from the deep brain stimulation surgery, that the patient will not get worse after getting the DBS surgery, or certain symptoms will not get worse after getting the DBS surgery. To achieve those two goals, there is a process of evaluation. In our center at University of Nebraska Medical Center, we have a process where the patient is evaluated in the clinic first to make sure the diagnosis is idiopathic Parkinson's disease or regular Parkinson's disease. Other types of Parkinson's, and there are many out there, are not responsive to deep brain stimulation surgery, so those need to be evaluated first in the clinic. And then we do what is called an on-off evaluation, where the patient is brought into the hospital, or in some places in the clinic, but at UNMC it's in the hospital, and medications are held for 12 hours or longer. Practically speaking, it's usually 16 hours or longer. And so the patient come into the hospital, get admitted, and the medication is stopped that afternoon for all Parkinson's medication. And we let the patient wear off of these medications so the Parkinson's disease shows up in an untreated state, with the limitation being that the medication's effect are not fully gone in 12-16 hours, and sometimes it can take 2 weeks or 3 weeks for the benefit to be completely gone. But we want a significant amount of benefits to go away, which does happen in 12 hours in most patients, although there are some exceptions where a patient is not fully off in 12 or 16 hours. In the off state, we perform a detailed evaluation with what we call a Unified Parkinson's Disease Rating Scale, or UPDRS, and other evaluations such as timed gait evaluation, get up and go test, and so on and so forth. And we in our center record all those evaluations to have a second look if there is questions or concern. And then the patient is given a challenge dose of levodopa, or a higher than usual dose of carbidopa, levodopa, or Sinemet to get the full benefits, so full on state. And patient is then evaluated again after patient is turned on with the similar rating scales and similar evaluation and gait examination. And again, it's videotaped, and we look for a significant improvement, which is at least 30% improvement with the medication, or ideally 50% improvement with medication. To look for the clear benefit to the medication, and that actually is also required by some of the insurance companies before they will approve for the deep brain stimulation therapy. And then we also perform a very detailed neuropsychological testing that requires a half a day or 3 hours of testing. That is usually done the day before in an on state, because being off of medication can impair your performance on these cognitive testing. And we look for many things in this cognitive testing that's beyond the scope of this video. And then we perform a very special brain MRI, which is called 3D brain MRI, to look for the planning for the wire or lead placement, but also to look for other complications, risk of bleeding. We look for other concerns such as microbleedings, and any other unusual feature of the brain MRI in relation to Parkinson's. And sometimes we find things incidentally on these MRIs, such as small tumors or benign tumors that need to be treated or watched for a while before we can actually go for the deep brain stimulation surgery. And after all of this evaluation, we sit down as a team with all movement disorder neurologists, our fellows, our nurse practitioner, nurse case managers, our neuropsychologists, their team and their fellows, the neurosurgeons, We will all sit in one room and we review the case one by one with all the evaluations, starting from the clinic evaluation and patient's goal of therapy, to see if we have high likelihood of giving benefit in achieving the goals that the patient have. And we want to make sure that there is no undue risks involved from the surgery for the patient.